Kanski lecture series, and this is a chapter 13, Retinal Vascular Diseases, part 5. And in this part, we are going to discuss about the retinal venous occlusive diseases. So, most of the time, we are going to discuss RVO, or central retinal vein occlusion, or BRVO, broad retinal vein occlusion. So, let's get started. Introduction. Retinal venous thrombosis is strongly associated with age related local and systemic factors. It is the second most common retinal vascular disease after diabetic retinopathy. So, it is very common after the retinopathy, after the diabetic retinopathy. In branch retinal vein occlusion, arteriosclerotic thickening of the branch retinal arteriole is associated with compression of venule at the atriovenous crossing point, exacerbating by sharing an adventitial sheath. So whenever there is an arteriosclerotic thickening, for example, if the arteries are getting thickened, so what is happening, it is compressing the venules at the AV crossing. So it is known as it is basically exacerbated by the sharing an adventitial sheath. So that is causing the retinal venous occlusion. This leads to secondary changes that include endothelial cell loss, turbulent flow, and thrombosis formation. So, whenever there is a blockage of passing of fluid, so this will cause the endothelial cell loss, there will be turbulent flow and thrombosis formation. Similarly, central retinal vein and artery poses a common sheath at a crossing point posterior to the lamina propria. So, the atherosclerotic changes of the artery that may precipitate central retinal vein occlusion. So, before the lamina cupreosa, so there is a crossing point of the retinal vein and arteries similar to that of AV crossing. So what happens that if there is an atherosclerotic changes in the artery, it will compresses the venule and will cause the formation of the CRVO. Hematological prothrombotic factors are thought to be important in minority, amplifying an atherosclerotic anatomical predisposition. Once venous occlusion has occurred, elevation of the venous and capillary pressure with stagnation of the blood flow ensues, resulting in a retinal hypoxia, which in turn results in a damage to the capillary endothelial cells, extravasation of the blood constituent, and liberation of the mediators such as VEGF. So once the venous occlusion occurs, so what it will lead? It will lead to the elevation of the venous and venous pressure, which will lead to the capillary stagnation. And what happened? It will result in retinal hypoxia, which will result in retinal endothelial cell damage. The blood will excavate, and there will be the liberation of mediators such as VEGF. So, what are the risk factors of the retinal venal occlusion? So, age is the most important risk factor. Over 50% of the cases occur in a patient older than 65 years of age. So, if a patient is older than 65 years of age, he has as a risk factor for the CRVO. So, hypertension is present in 2/3 or more of a RVO patient over the age of 50 years and about 25% in a younger patient. So, hypertension is one of the risk factors for CRVO. It is particularly important risk factor in the patient with BRVO. Hyperlipidemia is present in 1/3 or more of a patient, irrespective of a patient age. So, hyperlipidemia is very important. Diabetes mellitus is present in up to 15% of the patient over 50 years of age. So, diabetes mellitus is also a risk factor, and it is present over 15% in the patient over the age of 50 years. It is more prevalent in Asian and African patients, but it is uncommon in younger patients. Glaucoma and ocular hypertension are associated with high risk of CRVO. One of the most important that glaucoma also causes the CRVO. Oral contraceptive pill in younger female, the contraceptive pill is the most common and underlying association and probably should not be taken following RVO. Smoking, current smoking may be associated with an increased incidence of RVO. Uncommon causes are dehydration, myeloproliferative disorders, for example, myeloma, polycythemia. So, the thing which increases the thrombus formation, like polycythemia, thrombophilic diseases such as hyperhomocystinemia, antiphospholipid antibody syndrome, factor V Leiden mutation, inflammatory disease associated with occlusive periphlebitis, for example, Behçet syndrome, sarcoidosis, vaginal granulomatosis, orbital disease, and chronic renal failure. So these are all the causes, but they are usually uncommon. So how do you evaluate a patient with a CRVO? The detection and management of associated systemic disease is aimed principally at reducing the risk of the future vascular occlusive event, both ocular and systemic. So, all patients should have their blood pressure checked. Erythrocyte sedimentation or plasma viscosity should be checked. So, ESR is being checked for any kind of inflammatory marker. Full blood count is being done. Random blood glucose is being done. Further assessment of diabetes if indicated. Random total and high density lipoprotein HDL cholesterol. Additional lipid testing may be considered because hyperlipidemia is associated with CRVO. Plasma protein electrophoresis to detect dysproteinemia and such as multiple myeloma. To detect the uncommon causes. Other tests, some authorities advocate routine investigation for systemic and organ damage related to cardiovascular risk factor commonly found in patients with RVO. This is intended to help the prevention of the further non-ocular damage as well as facilitating systemic management to reduce the risk of recurrent ocular venous occlusion. So one can also do urea electrolytes, creatinine. So RFTs can be done to detect any kind of renal disease associated with hypertension. Chronic renal failure is also a rare cause of RVO. Thyroid function testing can be done. This is a higher prevalence of a thyroid disease in RVO patients. Electrocardiography, ECG, left ventricle hypertrophy is associated with hypertension. So selected patient according to clinical indication. So these investigations we discussed earlier, we can do it on all kind of patient, but sometimes when there is a in selected patients we do further investigations. For example, if they're very young patient who are suffering from CRVO, if there is a bilateral CRVO, so in these cases we can do the extra investigations. So, selected patients according to clinical indication. These tests might be considered in a patient under the age of 50. So, young patient in bilateral RVOs, patient with previous thrombosis or a family history of thrombosis. Some patient in whom investigation for common association is negative, and evidence of a causative link for many of these is limited. So, chest X-ray is done to diagnose sarcoidosis, tuberculosis, left ventricular hypertrophy in hypertension. C-reactive protein sensitive indicator for inflammation, plasma homocysteine level to exclude hyperhomocystinemia for which there is a reasonable evidence of an increased RVO risk. Thrombophilia screen can be done by convention. This refers to a heritable thrombophilia test type might include thrombin time and prothrombin. So PT, APTT are being done, and activated plasma partial thromboplastin time, antithrombin functional assay, protein C, protein S. So these are all the factors that are responsible for thrombosis formation. Activated protein C resistant factor 5 latent mutation, prothrombin G 2210A mutation, lupus anticoagulant, and in particularly anticardiolipin antibodies IgG and IgM. Autoantibodies can be found because of their association with occlusive vasculitis, rheumatoid factor, anti-nuclear antibody, anti-DNA antibody, anti-neutrophilic cytoplasmic antibody, ANCA. Serum angiotensin converting enzyme for sarcoidosis, treponema serology can also be done to detect syphilis, cardiac carotid duplex image to exclude the ocular ischemic syndrome. So next is a branch retinal vein occlusion, so which is a part of the venous occlusion. So diagnosis and symptoms. So symptoms and visual acuity depend on the anatomical location of the occlusion. If the macula is involved, a sudden painless onset of blurred vision and metamorphosia is experienced. Peripheral occlusion may be asymptomatic. So you know that there are 4 different branches that is being given in a case of a retina. That is a superior temporal, infratemporal, and supranasal, and infranasal. So when one of these branches are being affected, it gives rise to the symptoms. But most of the time when the temporal vein is involved, there is a macular involvement or foveal involvement as well, which can cause a foveal edema, and when the fovea is being involved, it will cause the blurred vision and metamorphosis. Iris neovascularization, so it is one of the complications of the BRVO, neovascular glaucoma, and NVI formation. So NVI and neovascular glaucoma are much less common in BRVO than in CRVO, 2 to 3% and 3 years. So it occurs almost 2 to 3% after 3 years. So fundus changes will show there will be the dilation and tortuosity of the affected venous segment. So the vein which segment which will be affected will be dilated and tortuous with flame shape and dot plot hemorrhages principally in the retinal area drained by the thrombosed vein through an thaw, and occasional hemorrhage may be identified elsewhere. Cotton wool spot and retinal edema may be present, but this is not inevitable. The supratemporal quadrant is most commonly affected. So, supratemporal quadrant is most commonly affected. The site of occlusion uh, may be identified as an arteriovenous crossing point. So, you can identify the occlusion point by the AV, where the AV crossing point. The acute feature usually resolve within a 6 to 12 months. So, if leaving venous sheathing, sclerosis, and variable, persistent, and recurrent hemorrhage. So, when the features have been resolved, there it will resolve after most of the time 6 to 12 months, and they will leave us venous sheathing, sclerosis of the vessels. So, there will be silver lining of the vessels, and there will be the variable, persistent, and recurrent hemorrhage. The severity of the residual signs is highly variable. So, retinal neovascularization occur in about 8% of the eyes with 3 years. So, first we discuss about the iris neovascularization. Now we will discuss about the retinal neovascularization. So, it is different because the neovascularization in iris is at the iris, and in the retina is in the retina. Most commonly, PRV associated with the optic disc neovascles. So, retinal neovascularization in about 8% of the eyes by 3 years. So, it is more than NVIs. The risk is much higher in eyes with more than about a 5 disc area of non-perfusion on FA over 1/3 of the eye. NVEs are more common than NVDs. NVEs usually develop at the border of the ischemic retina drained by an occluded vein. They typically appears within 6 to 12 months, but may develop at any time. So, if the area, or if you do FA and there is a area of non-perfusion which is about a 5 disc diameter, then it is most likely that retinal neovascularization will occur, and NVE will develop at the border of ischemic retina drained by an occluded vein, and they all usually develop within 6 to 12 months. So, if there is a chronic macular edema, can also be associated, is the most common cause of a persistent poor visual acuity after BRVO. So, collateral vessels may form near the limited capillary perfusion after weeks to months. So, vessels will form between the arteries and venules. They usually connect a poorly functioning to the normal functioning segment of the venous circulation and typically appear as a tortuous looping channel. So, collateral vessels can also be present. They may cross the horizontal raphe between the inferior and the superior vascular arcade. The appearance of the collateral is associated with better prognosis. So, if the collaterals are being formed, they have a better prognosis. Recurrent vitreous and pre-retinal hemorrhage and occasionally tractional retinal detachment can occur secondary to neovascularization. So, hemorrhage can occur, pre-retinal hemorrhage and tractional retinal detachment can occur secondary to neovascularization. So, let's see figure 13.25 is showing classification of the retinal branch vein occlusion. So, A is showing it is basically the types of BRVO. The BRVO can be major at disc, major away from disc, minor macular, and peripheral not involving the macula. So, major is like if the occlusion has been done at the venous end, like in a case of A, you can see that occlusion will be at this point, and B will show that it will be major but it will be slightly away from the disc. So, this is B is a major but away from the disc. C is showing us a minor macular. So, this is being involved, which is supplying the macula. So, when this is involved, this is showing a minor macular lesion. And D to F is showing the peripheral involving the macula, not involving the macula. So, you can see this is the symptoms of the signs of the fresh PRVO. So, A is showing a upper temporal branch vein occlusion with macular extension. So, you can see that the upper temporal area is involved with the macula is being involved. B is showing upper temporal venous engorgement and a cotton wool spot. So this is showing us a cotton wool spots here. And C is showing predominantly macular hemorrhage. So this is showing a macular hemorrhage. D is showing F is showing hypofluorescence area which is being affected by the venous occlusion. So this is an old BRVO, means that a BRVO has been settled and has become chronic. So you can see that this area has been involved because there are very thinning of the and sclerosis of the vein. So same here, there are ghost vessel present. So upper temporal branch vein occlusion with shunt vessel arrow. So this is the shunt vessels which are collateral. And upper temporal B is showing us a upper temporal occlusion with venous sclerosis and a chronic macular edema. C is showing reabsorbing hemorrhage and exudates and collateral vessels. D is showing F is showing area of non-perfusion and collateral vessels of the C. So next is basically that what will be the X-ray will demonstrate. Fluorescent angiography demonstrate peripheral and macular ischemia, capillary non-perfusion, staining of the vessel wall, vessel pruning, small branches failing to fill. So pruning is where the small branches will fail to fill. Hemorrhage and edema with collateral vessels commonly formed in established cases. So collateral vessels can also be seen. Venous filling is delayed. In later or subtle cases, FA may be diagnosed. The commonest underlying cause of a branch retinal vein occlusion is a systemic hypertension, which needs to be effectively treated to reduce the risk of a late cardiovascular and cerebrovascular complications. So how will you manage a case of a BRVO? So systemic arterial hypertension and hyperlipidemia should be controlled. So there first is a journal management. If present should be treated. Further investigations are required in order to determine the underlying cause in patient younger than 50 years. And in those with bilateral BRVO at presentation or those with the history of a recurrent BRVO. So in that case, further investigations can be done. Observation without information is usually indicated if visual acuity is 6/9 or better or slightly worse but improving. So if the visual acuity is 6/9 or better, so we can always observe the lesion. So what if there is a new vascularization of the retina is being present? How will you treat it? If the NVEs or NVDs are generally regarded as an indication for the sector photocoagulation, so we will do sector photocoagulation. Why it is called sector photocoagulation? Because you know that in a case of a branch retinal vein occlusion, one branch is being affected, so in that sector you will do the laser photocoagulation. You will not do the whole photocoagulation. Some authorities withhold treatment unless vitreous hemorrhage occurs because early intervention does not appear to affect the visual outcome. Burns of a mild to moderate intensity, 400 to 500 micrometer, actual diameter, 0.05 second duration, and spaced one width apart are applied to the ischemic area. So the same settings are being applied as for the PRP. FA can be used to confirm dubious NV if necessary and to demonstrate ischemic areas that might be specifically targeted with laser. Laser may be combined with a 4 to 6 weekly intravitreal anti-VEGF agent. So laser can also be combined with the intravitreal anti-VEGF agent. So let's see, figure 13.28 is showing us a treatment of a branch retinal vein occlusion. A is showing sector laser photocoagulation for the neovascularization. So in this case, the neovascularization has been done. B is showing FA appearance after the sector laser photocoagulation. So this is fluorescent angiography which is showing. C is showing OCT of a cystoid macular edema before and 4 weeks after the bevacizumab intravitreal injection. So this is showing a cystoid macular edema, and this is showing when the hemorrhage is being resolved. So next is how we will treat with NVI. NVI is an indication for urgent sector PRP. Secondary glaucoma is less likely to be aggressive than in CRVO. See chapter 11 for a detailed management of NVG. So for NVI, we can also do the sector PRP. So when we give the intravitreal anti-VEGF agent, so most of the time when there is a associated macular edema, we give the intravitreal anti-VEGF agent. These have been widely adopted for the treatment of macular edema secondary to BRVO. All available agents are effective in these circumstances, but repeated injections are needed. The Bravo studies show that a ranibizumab is superior to the traditional grid laser treatment at for 12 months. The conclusion is confirmed by the Vibrant study, which reveals that visual acuity gain established after monthly injection of aflibercept can be maintained with when required treatment. So basically, it is showing there is a Bravo study which is basically studying the ranibizumab, which is is more superior to grid laser. Next is a Vibrant study, which is basically studying the aflibercept and the visual acuity gain after monthly injection uh, of the aflibercept can be maintained when required treatment. When required treatment means that you do OCT or other things to determine the macular edema. If it is still present, then you give injection. Otherwise, you do not give injection. Commence treatment as soon as the diagnosis is made. Combining intravitreal injection with a laser may allow a reduction in the frequency of injection, but the optimal regime has yet to be defined. Intravitreal dexamethasone implant. This confers visual improvement in BRVO substantially superior to observation alone. So, intravitreal dexamethasone implant can be used. This treatment can be repeated 4 to 6 months because the implant life is almost about 6 months. The adverse effects include a glaucoma, increased glaucoma, and cataract risk. As with anti-VEGF therapy, it may be used alone or in conjunction with the laser. So, when you can do the laser to the macula, with the advent of the intravitreal treatment, macular laser has become less popular. So now we don't do macular laser and should be regarded as an adjunctive or combination modality. If visual acuity remains 6 by 12 or worse after 3 to 6 months because of the macular edema that is associated with good central retinal, central macular perfusion, an FA laser may be considered. So, if the visual acuity, which is almost if it is less than 6 by 12 or worse, even after 3 to 6 months because of macular edema, then laser can be considered. 12, 20 to 100 mild burns of a diameter 50 to 100 micrometer and duration of 0.051 to 0.05 second, concentrating on areas of a leakage on FA. So, in a case of a macular laser, we use a less spot size, almost about the 50 micrometer size, because it is very close to the fovea. So, one should be very careful of these laser. Pulses at a shorter end of duration range seems to inflict less damage to the retina while exerting an approximately comparable therapeutic effect. Treatment should not encroach within a 0.5 disc diameter of a foveal center. So it is same that one should not treat in the almost 500 micrometer to the center of the fovea. Retinal hemorrhage and blood vessel special collaterals should not be treated, and collaterals should not be treated with photocoagulation. Then there is a subthreshold micropulse laser appears to be as effective as conventional photocoagulation for macular edema and inflicts considerably less retinal damage. The onset of action is slower. So next is an intravitreal triamcinolone for macular edema. So intravitreal triamcinolone in a preservative-free preparation is as effective as laser in eyes with macular edema, but has a less sustained effect at a relatively higher rate of cataract formation and IOP elevation. So, how do you do review? Review in cases that do not require early intervention should take place 3 months and then 3 to 6 monthly interval up to 2 years, principally to detect the neovascularization. So, you do almost review should be done 3 monthly, then after that you do it 6 monthly and for 2 years almost. OCT allow rapid quantitative analysis of a macula and has become an important in the assessment and subsequent management of the retinal vein occlusion. Prognosis. What is the prognosis of a BRVO? BRVO generally has a good visual prognosis. 50 to 60% of the patient maintaining a final visual acuity of better than 6 by 15 even without treatment. So the visual acuity should be greater than 6 by 15 most of the time. In a 50 to 60, half of the patient you can say. Poor prognostic factors are chronic macular edema, macular BRVO, new vessel formation leading to vitreous hemorrhage. So, when the macula is being involved, it leads to a poor prognostic factor. About quarter are left with the visual acuity of 6 by 60 or worse. So, or 1/4 are left with visual acuity 6 by 60 or worse. Developing BRVO in one eye slightly increases the risk of a similar event occurring in a fellow eye. So next is an impending CR, central retinal vein occlusion. Central retinal vein occlusion. So it is showing us the sign of the central retinal vein occlusion, but there is not a full blown central retinal vein occlusion. So impending or partial CRVO on average occur in a younger patient than those developing with severe occlusion. The prognosis is usually good, but the proportion will deteriorate to ischemic CRVO. So most of the time prognosis is good, but sometimes it also lead to ischemic CRVO. The distinction between the impending and a mild non-ischemic CRVO is not clear and may be artificial. So you know that CRVO has been divided into different types. Number one is a ischemic CRVO and non-ischemic CRVO. And major difference is basically on the severity of the signs. The non-ischemic CRVO basically have a less signs. So sometimes distinction between the impending and mild non-ischemic CRVO is not clear and may be artificial. Symptoms may be absent or consist of only minor or transient blurring that is considerably worse on waking. On examination, there is a mild retinal venous dilatation and tortuosity. So there will be the venous tortuosity and dilatation with relatively few small scattered dot and blot hemorrhages. There may be mild macular edema. Fundus autofluorescence may reveal a fern-like perivenular appearance, and FA generally demonstrate an impaired retinal circulation. So FAF will show us a fern-like perivenular appearance. So the area around the perivenular area will be like fern-like, and fluorescent angiography will demonstrate an impaired retinal circulation, means that there will be the delayed retinal filling. Treatment is empirical with the lack of an established evidence base. Correcting any predisposing systemic condition, avoiding dehydration, and lowering IOP to improve perfusion have been postulated. Antiplatelets agents, other anticoagulant measures, and hemodilution are of no proven benefit but may be considered in some cases. So let's see figure. So this is an impending CRVO. So you can see that there is a dilatation and tortuosity of the retinal veins, but there are very few or less scattered hemorrhages. So that's it for the part 5. See you in the next lecture.